Hi, this is Dr. Walaa. Today we're going to talk about 3 basic steps for temporomandibular diagnosis. To efficiently diagnose temporomandibular disorders, you should know the differential diagnosis by knowing the classification, knowing the diagnostic tools that will help you reach up the final diagnosis, and finally interpret the radiographic image to reach the final diagnosis. Okaeson 2008 introduced a classification of TMDs into mastocytory muscle disorders, TMD disorders, chronic hypomobility disorders, and growth disorders. This classification was updated later by Schiffman et al. 2014 into different categories. Schiffman et al. Added neoplasm, hypertrophy, and movement disorders like orofacial dyskinesia and oromandibular dystonia to the mastocytory muscle disorders. Also, he added joint pain, and hypomobility disorders, joint diseases, fractures, and congenital or developmental diseases to temporomandibular disorders. Chronic mandibular hypomobility disorders include bony and fibrous ankylosis, myostatic and myofibrotic muscle contracture. Also, growth disorders include congenital developmental bony disorders such as agenesis, hyper or hypo or neoplasia. Congenital developmental muscle disorders include hypertrophy, hyperplasia, and neoplasia. Heading to the diagnostic tools, 3 basic steps are indicated to reach the final diagnosis, mainly history, detailed history from the patient, clinical examination, and additional diagnostic tests. A questionnaire may be passed to the patient even before dental visit, asking him different questions for initial evaluation before interview, like if he has pain, difficulty on chewing, talking, using jaw movement, pain in around the ears, temple, cheek, frequent headache, neck ache, toothache, noises in jaw joints, recent trauma to the head or neck or the jaw, recent changes in the bite, previous treatments for joint problem or unexplained facial pain, any experience of jaw stuck or locked or go out from the patient, feeling of stiffness or tightness. After these questions, we may proceed for detailed history taking from the patient. Detailed history is an essential step to reach the final diagnosis. Chief complaint could be one or more, but it should be taken in patient own words. It's very important. Location of the chief complaint, where is it located, when it happened, if it's associated with trauma, systemic disease, or spontaneous, and characteristics of chief complaint in terms of quality, temporal behavior, localization, intensity, duration should be taken in details also. Medical history, past, present, or any previous operations or treatments or current medication or serious illness should be discussed with the patient, as it may affect the treatment plan or be the cause of chief complaint. Rapid review of systems performed, considering cardiovascular system, CNS, GIT, respiratory, and correlation with chief complaint. Also, psychological assessment is performed quickly. But the quality of pain means, is it itching, stinging, burning, aching, or pulsating? Temporal behavior means behavior of the chief complaint with time. Is it continuous, intermittent, with pain-free intervals, recurrent, with extended free intervals? Is the pain localized, diffuse, radiating, or rapidly change the location, lancinating, or the intensity in terms of mild, moderate, or severe? A scale like VASA scale, visual analog scale, from 0 to 5 or 0 to 10, being 0 is the no pain and 10 is the most severe pain, should be recorded and is useful in the follow-up in assessment treatment success. Duration of pain, is it momentary for seconds or prolonged for hours or even days? The manner of flow of pain, is it continuous or paroxysmal, with attacks variable in intensity and duration? The associated symptoms could be sensory, motor, or autonomic. Sensory like hyperesthesia or hyposthesia, or anesthesia, paresthesia. Motor changes like muscle weakness, contraction, or true spasm of the muscle. Autonomic changes associated with the chief complaint could be around the eye in the form of increased lacrimation or edema of the eyelid, or even congestion. Could be nasal in the form of increased secretions or congestion. Could be in the GIT in the form of nausea or indigestion. Skin may change the skin color, temperature, or sweating. Factors which increase, aggravate, or decrease the pain, such as chewing, brushing teeth, shaving, or yawning. All this may increase the pain. Factors also, emotional stress, increased stress to the patient, or improper sleep in the form of quality or disability could be increasing the pain or aggravating factor. Patient should be asked also about previous treatment, consultation, or any previous appliances that has been performed, and about their success. And patient should be asked also about if there is a similar complaint in other part of the body, as the condition or chief complaint could be a part of a systemic disease that may be treated first. Clinical examination is performed to exclude other sources of pain, and we should make gross examination first, starting from facial symmetry to detailed examination that may include cranial nerves, eye, ear, cervical, muscles, TMJ, dental, and occlusal examinations. For the above mentioned, if any of them is positive, referral to specialists should be performed. To exclude neurologic disorders, rapid assessment of cranial nerves may be performed. We're going to focus on oculomotor, trochlear, and abducent by moving the index finger in the main 4 directions: north, south, right, and left, and the accessory directions between them, and let the patient eye move with your finger in these 8 directions without moving his head, and you should examine that the eyeball moves in these 8 directions. For the oculomotor nerve, direct and consensual light reflex is examined by applying torch to one eye and examine if the pupil is constricted. This is the direct reflex, and if the another pupil on the other side is constricted, this is the consensual light reflex. Moreover, approaching the index finger in front of the nose of the patient from distance and approximating it to near his eye, the eyeballs both should converge to the midline with your index finger. This is the accommodation reflex. Here, perilla means the pupils are equal in size, round, reactive to light, and accommodation. 3 main steps to examine trigeminal nerve. Sensory by applying instrument or cotton on the forehead, cheek, or jaw, which are supplied by trigeminal nerve. Corneal reflex by applying sterile cotton on the cornea to see the patient blinking for positive corneal reflex. The motor test asking the patient to clench his teeth. This is test the temporalis and masseter muscle, which should contract equally bilateral. Facial nerve, 2 main components should be examined. Taste sensation by applying sugar or salt on the tip of the tongue, and the patient should differentiate between them. The motor, which tests the muscles of facial expression that the facial nerve supply, by asking the patient either to smile, raising the eyebrows, show the lower teeth, etc. Vestibulocochlear nerve has 2 components, hearing and balance. Hearing, we usually test for gross hearing by rubbing hair strands of the patient between thumb and first finger and compare both sides beside the ear and ask the patient if he hears that. Balance by letting the patient walk heel to toe along straight line. And we may ask him about any changes in hearing or upright posture. Usually cranial nerve 9 and 10 or glossopharyngeal and vagus nerve are tested together as they supply the back and throat. We ask the patient to say ah sound, and we should notice equal bilateral elevation of soft palate, and gag reflex should also be tested by touching the both sides of the pharynx by an instrument or cotton ballet. Cranial 11 or spinal accessory nerve is simply tested by asking the patient to shrug his shoulders against resistance, and let the patient ask the shoulder and resist it, and test the tone of the muscle and his ability to do that. Also ask the patient to move his head side to side against resistance. This tests the sternocleidomastoid muscle, and shrugging shoulder testing the trapezius muscle. Cranial 12 or hypoglossal nerve is examined by asking the patient to protrude his tongue, and we should check any abnormality or deviation from the midline. Also, we should ask the patient to push the tongue laterally against cheek, and using tongue blade or finger to check the muscle strength from outside. Eye examination is done for gross abnormalities, for any tear or swelling, the eyelids, redness, and patient may be asked to cover one eye and read few lines from a paper, and you record any blurring, diplopia or pain in or around the eye. Ear gross examination is performed for any abnormalities or secretions or pain, swelling, changes in color. Because of the proximity of TMJ and muscles of mastication and common trigeminal innervation with the ear, this should be performed. And any actual ear disease diagnosed or identified should be referred to specialists. Because neck pain can refer to the masticatory muscles, we should record pain and limitation of movement. If there is cervical problem and limitation in the neck movement, extension by passive stretching of the muscle can be performed if the problem in the muscles, while if it is vertebral, no more extension or increasing the movement could be performed. Before heading to detailed muscle examination, few tips regarding the palpation of the muscle and functional manipulation should be understood. How to perform accurate palpation. Palpation is performed with the inner surface of the index finger and middle finger and the thumb, with circular motion in the form of prolonged firm thrust more than shallow thrust along the whole length of the muscle and at the origin and insertion, while taking feedback from the patient about any pain he feels during palpation and if he wants to discontinue the palpation procedures. Moreover, during palpation, an important part is to search for trigger points. Trigger points is a firm, tight band of muscle which its palpation may refer the pain to the whole muscle or where the patient feels the most painful part. When to perform palpation and when to perform functional manipulation. Palpation is performed for muscles accessible for direct palpation like masseter and temporalis cervical muscles, while muscles like pterygoids, medial and lateral pterygoid are inaccessible usually for palpation, so functional manipulation is performed. However, in few cases, pterygoids may be accessible for palpation but may elicit false positive results, meaning that being inaccessible for palpation, trying to reach the muscle for palpation may elicit pain even in non-painful muscle. Functional manipulation simply is to manipulate the jaw while the muscle is performing function, like pterygoid, lateral pterygoid, responsible for protrusion of the muscle. We perform resistance to the jaw during protrusion, so if pain is elicited, so the lateral pterygoid is the problem, as we'll see later. Cervical muscles, we here discuss sternocleidomastoid muscle. As we said before, the muscle is examined along the whole border, anterior and posterior border, and the origin, at the clavicle and insertion at the mastoid process. And while examination, take feedback from the patient about the points of pain or any trigger point you felt below your index finger. It's better performed bilaterally from behind the patient and compare the two sides. Trapezius muscle has 3 types of fibers: superior, middle, and inferior fibers. Trapezius muscle is examined, as we mentioned before, for any areas of tenderness or trigger points. After finishing the cervical muscles, we examine the 4 muscles of mastications named temporalis, masseter, and medial and lateral pterygoid. Temporalis and masseter are accessible for direct palpation, taking into consideration the direction of muscle fibers and the same way of palpation in a circular motion bilaterally, comparing the 2 sides and searching for trigger points beneath the index or middle finger, and recording patient feedback of any pain sensation. And don't forget to examine or palpate the temporalis tendon, which is inserted at the coronoid process. This is only addressed by intraoral palpation along the anterior border of the ramus, heading up to the coronoid process, at which the temporalis tendon is palpated. A condition is called temporal tendonitis. Heading to the pterygoids, medial and lateral pterygoid, they are not accessible for direct palpation, only by functional manipulation, in which we manipulate the jaw during function of these muscles. And as we know, the fatigued muscles or inflamed muscle, any function like contraction or stretching of the muscle fiber will increase the pain. Medial pterygoid is one of the elevator muscles which elevate the mandible during function, leading to closure. So if you let the patient clench his teeth, there will be increased pain. In the same way, lateral pterygoid is the main protrusive muscle that allow protrusion of the mandible. So if you resist this motion, an increased pain will occur within the muscle, and this will be reported by the patient and recorded. By the way, clenching the teeth will not only induce pain in case of medial pterygoid problem, also in case of intracapsular disorder, pain will be increased by clenching the teeth, as it may increase the intracapsular pressure. So if you place a tongue blade on one side or both sides, there would be no pain in case of the intracapsular disorder, while it will be increased in case of problem in the medial pterygoid. Here in the intracapsular disorders, the left side, here is the normal arrangement of TMJ components: articular eminence, condyle, and disc. The right side is disc derangement disorder, which is anterior disc displacement without reduction or closed lock. The patient will point to the TMJ in terms of pain with his index finger rather than touching his face with the whole hand. Different sounds could be heard in case of intracapsular disorders, such as clicking, popping, or crepitation. Crepitation is usually heard in a final stage osteoarthritis. And other finer sounds could be heard with a stethoscope applied to the outer surface of TMJ in front of the external auditory meatus. In case of mouth opening restriction due to closed lock, meaning disc displacement without reduction, or pain that limit the patient from opening his mouth, the examiner used 2 fingers trying to increase the mouth opening and feel whether the end feel is soft end feel, meaning that it's muscle pain that limit the mouth opening, or hard end feel in which there is an obstacle in front of the condylar head that prevent its increasing in opening, where is the anterior displaced disc creating that obstacle. Other than the degree or the distance of mouth opening that should be recorded, the pathway the mandible takes during opening should be examined also. Flexion is a midline shift during opening that doesn't return to normal, while deviation is deflection from the midline to bypass an obstacle which is an anterior displaced disc in one side, then return to the midline. Dentition is rapidly examined for any caries, periodontal disease, and radiographically for any pulpitis or preapical lesions that may cause pain. Occlusion is also examined for centric and eccentric occlusal contacts, where facets or fractures which might indicate a bruxism during night. Moreover, bite registration and Facebook records may be obtained for 3D dental and occlusal examinations.